TopMedTalk.
Well, hello and welcome to TopMedTalk here at Anesthesiology 2024. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree Chappell. I'm your host. I'm joined by my co-host, Professor Mike Grocott. Hello, Mike.
Good morning, Desiree.
We're at it again, aren't we?
We are.
We had a full schedule yesterday. Today is much of the same, but amazing, outstanding presenters, guests, key opinion leaders from all over the world joining us. So check us out at TopMedTalk.com, on social, on YouTube. You can hear a lot of the conversations that we've been doing, so check that out. We did want to give a huge thank you to the American Society of Anesthesiologists for supporting us to be here in the exhibit hall with this beautiful booth. We couldn't do without you. Or our sponsors, Edwards Life Sciences, GE Healthcare, and Medtronic. Without you, we cannot keep TopMed Talk open access to the entire world completely for free. So thank you very much. Mike, as we've said before, we've had some outstanding guests.
But we're raising the bar.
We are raising.
No pressure, guys.
None of them were available.
So, first of all, we have Professor Andy Shaw, who has been with us plenty of times here on TopMed Talk. We did ask you back, Andy, so you must have been doing something right.
Yes, so. Well, good morning, Desiree. Good morning, Mike. Good morning, everybody. Thank you very much for the opportunity to come and talk this morning. My name is Andy Shaw. I'm a cardiovascular anesthesiologist intensivist at the Cleveland Clinic in Ohio.
Fantastic. Well, we're very excited about the next guest as well, who's new to TopMed Talk, Dr. Courtney Maxey-Jones. Courtney, thank you so much for joining us. Why don't you tell us about yourself?
Well, thank you so much. It's an honor to be here. I'm happy to be at the anesthesiology meeting, and I'm happy to participate in this podcast. I'm a cardiac anesthesiologist intensivist, and I actually currently work, for myself with my own PLLC, where I'm focusing on sort of like influencing the care of sick patients in multiple hospitals in upstate New York.
I love that. So consulting and sticking around in the New York area, or are you?
I'm from the Syracuse area, so it's wherever I can get in a reasonable drive radius is where I'm hanging right now.
That makes sense. Kind of wanted to do a bit of a revisit before we get kind of deep into the conversation. Andy, at EBPOM Ireland this year on the Dingle Peninsula, in Dingle, we had a great presentation about some work that you were presenting on danger shock.
Mm-hmm.
Can you take us back a little bit and run us through what that was talking about?
Sure. So the session in Ireland was a follow-on from one we did in London, and it's to raise awareness about new data in the temporary mechanical circulatory support ecospace, if you will, particularly the use of microaxial flow pumps, or impella, as everybody knows them perhaps more commonly. And so danger shock, let's talk about that for a minute, was a large, by MCS standards, randomized controlled trial published in the New England Journal earlier this year that demonstrated in STEMI shock, so cardiogenic shock occurring after a large myocardial infarction, a survival advantage. And you might say, okay, well, there's lots of those. Well, the truth is there aren't. This is the first in the mechanical circulatory support space to demonstrate a survival advantage. One of the things, however, that we also learned was that survival advantage is associated with a fairly significant complication burden. And so the conversation now turns, how can we make that safer? How can we make this space a bit less messy, literally and metaphorically, and that so that more people, maybe even beyond STEMI shock, can benefit from microaxial flow pump support. And Courtney has a huge amount of experience, which is relatively unusual in the anesthesia space, so I'm really looking forward to talking to her about some of the practical aspects of how she got into this, how we do it. But danger shock has changed the discussion, not from should we use this technology in STEMI shock, but how can we make it safer? And so we can get into that, some of the issues, some of the ideas that people like us have to perhaps make the device and the technology more accessible to people, because we know it works now.
Yeah. We're kind of going to come full circle back to this, but Courtney, for all of us frontline clinicians that have no idea what impella is or means, can you kind of start there and just go back to the basics on what is this device? We talked to Asad Osman yesterday kind of about the evolution of this device, but talk to us specifically about what it is and what we are seeing in practice when an impella comes to us.
Well, I think, and I don't mean to deviate, but I have to go back just for one moment to danger shock, because interestingly, and you can correct me if I'm wrong, that yes, there were significant complications associated with the arm who received the microaxial flow pump compared to the arm that did not, But the actual number of complications related to the intervention arm was somewhat similar to what the ECMO and balloon pump arms had. So now this is my very rudimentary interpretation is I'm dying. I'm going to be given a device to try not to die. So all of the devices have complications, but now we have one that might help me live with my complications, but I choose the one where I live. And, so that I didn't mean to go up. No, this is perfect. I thought that was but
like I said, the discussion isn't about whether you use the device or not.
Right.
The responsibility now shifts to us to make it safer, easier.
I totally agree.
And to reduce the morbidity burden now that the mortality question is answered.
Someone answered. It is answered, not somewhat. Yeah.
And so I think getting back to what you actually asked me was regarding how these, that we're referring to them as microaxial flow pumps, or they're often being referred to as percutaneous ventricular assist devices. Specifically, we're talking about the left-sided devices. And the benefit of these truly are the relatively minimally invasive way of supporting what the body actually needs when you've reached this severe level of shock, that you actually are in need of forward flow and an artificial form of cardiac output. And that's what these devices actually provide. They are placed across the aortic valve with the inlet being within the left ventricular cavity. And then using, impella comes from impeller, so rapidly spinning device that actually then is able to take blood physically from within the left ventricular cavity and place it into essentially the aortic root, because the outflow of the device sits just above the aortic valve. And so the physiology is perfect because you're getting what the body needs in terms of flow. And with that flow, not only is your cardiac output going up, but so is your mean arterial pressure, which relates to the cardiac power output increasing, which we know to be, the strongest independent predictor of in-house mortality. And along the way, it's not only helping the organs, it's helping the heart, because we know that coronary perfusion pressure depends upon diastolic blood pressure and the LVEDP. So the impella, it actually decreases the LVEDP and at the same time increases diastolic blood pressure, resulting in improved coronary perfusion. So body not dead because flow, and heart not dead because perfusion. Right. So I
said take it to the basics.
Yeah.
Nailed it.
This concept of LV unloading is really important, not just in the STEMI shock space, but, we spend a lot of our time, both of us, managing, VA ECMO patients. And this idea that allowing the heart to rest and recover isn't just a theoretical construct. There's some pretty early basic science suggesting that if you do rest the ventricle, it can remodel, it changes its metabolism, it changes the gene expression profile, but the physiology is extremely attractive. So this idea of LV unloading in the broader ECMO sense is very important as well. We can get into that later on.
Yeah.
Can I ask Courtney in particular? I know you both have considerable experience with these devices, but I think many of our listeners won't. And so you talk about percutaneous placement. A couple of things. I know there's two devices, and we have to distinguish between that. But also, are we talking about placement in a cath lab? Are we talking about intensivists or anesthesiologists placing them in theatre or in ICU? How complex is the procedure?
Well, I think to answer that, we do have to address that when we're talking about the left-sided impellas, we have two, in our pocket, so to speak. So we do have the smaller one, the Impella CP, which is capable of flowing up to 3.5 liters. And that one truly can be deployed traditionally by an interventional cardiologist directly percutaneously through the femoral artery. So that oftentimes, especially in, that's why it was selected for danger shock, because the benefit is almost instantaneous placement in the cath lab. The alternate device for the left side is the Impella 5.5, and so that flows 5.5 liters, so convenient. That one, because it's a larger device, it's percutaneous-ish, because what it requires is a graft to be sewn in place. So either kind of on the subclavians or directly off the aorta. So traditionally, that's a cardiac surgeon or a vascular surgeon doing it, but I wouldn't advocate for we just go to a sternotomy just to place the 5.5, but I would strongly advocate for placing it in the subclavians, because the other thing about the 5.5 besides, 5.5 liters of cardiac output is enough for almost everyone. And the other benefit of it, which one of my future bumper stickers is going to be, get it out of the groin.
Yeah.
Because as an intensivist, turns out if I can make my human a human, meaning sit them up, walk them around, and with the 5.5 being out of the groin, I think that's a major attractive feature, because then I've spent a lot of time, and I'm sure you have as well, where we, tie the patient down to the bed with VA ECMO and this and that and a trach and a peg, and the heart got better. And now we have this shell of a human being that now has to recover. With the Impella 5.5, I call it, we now can recover in parallel, body and heart at the same time, as opposed to previously we had to do it in series, meaning we'd hopefully recover the heart and then the body. So what I'm seeing is Impella 5.5 patients who get discharged home. No rehab, no nursing home. They go home.
And are we likely to see a 5.5 solution or similar that is truly percutaneous?
They're not FDA approved or advocated for, but people are pushing the envelope in terms of placing 5.5s without that grab. So I think that there's a lot of exciting opportunities and areas for evolution to truly get it to the point where, he and I can just put it in the patient.
My guess is down the line, the technology is developing so quickly that that devices will get smaller. Well, we need to get to 4.5, 5 liters a minute. How small you can be and achieve that, I don't think is figured out yet. But my guess is that that's where this technology is going. Yeah.
Okay, so very basic question, rudimentary. So traditionally, I would have known an intra-aortic balloon pump that I worked in the ICU. That's what we had. ECMO really wasn't even a thing back in the day in my ICU. All temporary devices, all things that are just support. Is this something that is not temporary? Is this a long-term solution? How long can an Impella device stay in? What are we looking at here?
Well, that's a loaded question, because there's the FDA answer.
Okay.
And then there's what I actually do. Yes, they all would, Impellas would fall under the same category of acute temporary mechanical circulatory support. And obviously unique to me is that I'm not at these fancy, impressive places. I'm not. My option, the end of the line in my institutions, is the 5.5.
Yeah.
So I don't have obviously I can transfer the patient and that sort of thing, but I've found that turns out a lot of people, we used to just be like, oh my gosh, transfer, get them out of here. Yeah. And now it's actually if I just wait longer with unloading and with these good practices, and again, the FDA approval for the 5.5 is 14 days. However,
that's what I was going to ask.
14 days. However, I've had them in place for 6 to 8 weeks.
Yeah, we have to.
Wow.
I just want to highlight something Courtney said earlier, which is this idea of allowing parallel recovery.
Yes, that's but
getting
to
out
my
of the
point.
groin into the axillary position, or even escalating if you have a CP and it's not enough.
Yeah.
Very few patients can't escalate to a 5.5, and then you can get the tracheal tube out, all the other pipes, you can mobilize. And this concept of parallel recovery as opposed to series is a really unique way of thinking about that.
Yeah.
So I guess we've covered the benefits in depth. Andy, you were trying to lead us earlier on down the path of these complications. How much of the complications do you think be mitigated by developments of the technology, and how much by sort of countermeasures, if you like, that we institute?
Well, I think we need to look at our own practices. I mean, all of us have worked in intensive care units, and I say to people who aren't medical, you've seen one intensive care unit, you've seen one intensive care unit. And even within that ICU, there's incredible variability in the way that we do things. And we've learned from other, medical disciplines, and ours, anesthesia. If you reduce needless variability, then quality improves and things become safer. And so I think there's a lot of work to do in anticoagulation, sedation, mobilization, feeding, pain control. All of that has to be figured out. So I think we can move the needle a long, long way before we say to the engineers, right, you're it.
Yeah.
I think there's a huge amount of work we can do.
I think what I heard you say was that the complication profiles are very similar, whether it's an intra-aortic implant or ECMO.
Yeah.
Why haven't we done that already?
Well, it's a very good question. I think a lot of the use of these sorts of technologies has been presumptive, so we presumed that they're a good thing to do.
Yeah.
Well, now we know they are.
Yeah.
So now there's a real onus, because presumably use of this technology will increase.
Yep.
Because there's a survival advantage, right? And when people figure that out and realize, they're going to say, I want that for my dad,
Yep.
or my mum or son or grandpa
Yeah.
or grandma. And so it's a very good question. Why is it still so messy in the ICU? Because it is.
Yeah.
And I think now we have a really good reason to come together and say, right, what's best practice for anticoagulation? What's the best way to measure heparin effect? Do you need to use heparin? Do you need to anticoagulate or not? And if you do, how do you do that? How do you increase the... There's so many different questions, and that's just one small example.
Yeah.
What's the balance between bleeding and thrombosis? We don't really know that.
Yeah.
We'd love to think we do, but we don't.
Yeah.
So we've got to stop guessing, I think, and start studying the problem, minimizing variability where we can. I'm not advocating for cookbook recipe-based medicine.
Absolutely not.
You've got to start somewhere, so start somewhere sensible.
Yeah.
And if we don't know, let's study the problem and find out.
Yeah. So, not switching gears so much, but to learn a little bit more about impella before we come back, it's a couple questions I still have around that. So there's a left-sided impella that is either put in during surgery or put in the interventional radiology.
Yes, so two left-sided devices.
Left-sided. So you said something about a right-sided.
There is a right-sided device as well.
Okay.
It's called the Impella RP Flex, and it is a percutaneous RVAD, which truly is percutaneous because you're accessing the venous system. And it can be placed. Before, I wasn't a huge fan of the initial version because it required it to be in the groin. But now the new one can go in the right IJ. So you can actually now, choose your univentricular support, and this is a whole other thing that we could talk about, but I've become a believer that we don't need VA ECMO as often as we think we do, because if we would treat the univentricular shock, which it almost always starts as, in a more appropriate, timely manner, we could avoid making it all the way to VA ECMO. And so that's why I like that with the Impella host of options, I can figure out which ventricle is the problem, and then support that one separately. And I believe, just as you've alluded to, unloading, and there's a bunch of things about ECMO that save the body, but not the heart, if that makes sense. So I think that's why I like, and having these devices. Well, yes, they're different. There's difference between the CP and the 5.5 and the RP. The principles of management are quite similar. And furthermore, the principles of the left-sided devices in particular are the same principles for which you would treat a patient who has a durable LVAD. So it turns out if you just learn the physiology, you can apply it broadly across your patient populations.
Yeah. And then we talked about who puts it in. So on the right side, is that still an interventional cardiologist? Is that a cardiac surgeon, or is that team anesthesia?
Well, all of the above, we'll say. I push the envelope, so I probably do more things than traditional anesthesia intensivists, and arguably more things than I should. But no one tells me no, and I'm a believer in easier to get forgiveness than permission. So, and I've had the luxury of really, frankly, working with wonderful interventionalists and cardiac surgeons who have supported me in my desire to push the envelope. But traditionally, I think it's placed largely by the interventional cardiologists. I don't know about your experience.
Yeah, on the right side, in our institution, it's the CVICU procedure and ECMO team that
Okay, gotcha.
And the last one we put in was last week, actually, and it was one of the... Well, I'm lucky that I have a heart surgeon on who's also an intensivist. He works full-time in our unit, and he happened to put it in. So, he was a surgeon. You don't need to be, though. Yeah. You just need to be able to put a pulmonary artery catheter in. Yeah. Then put a large pipe into the jugular vein, and most of us can do that.
Yep.
I think that's definitely going to change.
Interesting. So let's talk about the anesthetic considerations. So first of all, are we doing anesthesia for these procedures? Obviously, if they're having open chest and they're putting CP or the 5.5.
Generally speaking,
it would be.
Ostomy involved. There's usually an anesthetic.
Usually. But whenever they're doing it percutaneous or in interventional radiology, are we still there?
Not necessarily. I mean, I'm there because I go to make sure it gets put in, and I walk the fine line of persistence to annoyance. But generally speaking, no.
We're not doing anesthesia for it or MAC or anything.
No, it's considered within the
local
routine care provided in the cath lab. That's typically just nursing sedation.
Interesting. Okay.
Yeah, same for 5/5 placement in the ICU, which does require a small incision. But so much of this sort of thing is done in the unit, and the boundary between who provides sedation and who provides anesthesia is definitely blurred.
Yeah.
Can I ask you to speculate a little bit about, I mean, say we've got a clear indication, we've got a lovely randomized controlled trial.
In STEMI shock.
Exactly. Where else do you think we might sort of see these being...
So, well, let's ask a very basic question. Why do we use inotropes with vasopressors, which are profoundly toxic, and not physiological at all? The reason is because if you don't, people die. Well, let's move forward to ASA 2054. Now maybe there's a device that can be placed via a radial artery, threads around and can provide 4 liters of, who knows? So maybe there is, in the future, an alternative to these profoundly toxic medicines that we use. Maybe something like that. In between now and then, this idea of protected non-cardiac intervention, so protected PCI, protected non-cardiac surgery, protected bariatric surgery. Maybe there are a population of patients who are currently being denied surgical cure, treatment, whatever, because they're quote-unquote too sick.
Yep.
So I think that's going to be a real thing. And that's one of the reasons I think people like Courtney in our space who use the technology every day, I think it's so important, because you get the idea. Someone's coming, they've got an EF of 5-10%. They need a hip surgery, say.
That's it.
And call her. She can come and pop a device in, do the case, take it out at the end. I think that's on the table for us. I don't know what you think.
I totally agree, and I think even the step before that, where I think that cardiac anesthesia can make a big influence, and what I'm trying to do as well, is that even using impella 5/5s to support people for cardiac surgery that might have otherwise been determined your EF is too low, the targets aren't good, whatever it may be. So I think we're still working through that intermediate step, is my opinion, of making this device routinely used in people that are high risk for cardiac surgery. And then as people get comfortable with it being used and seeing the amazing things that I'm personally already seeing, then that's when you'll have enough inertia to then make it to that next
I can tell you, in our institution, the days where people took 2, 3, 4 times to get off bypass and come out on rocket fuel are long gone.
Yeah.
If someone doesn't come off quickly, because the chest's open, they'll just sew a graft right on the aorta, put 5/5, done, come off with minimal support. And that really matters. And I think you reduce total pump time, you don't hammer the heart with inotropes, vasopressors, and the lungs improve, and you can wean the feet. They can still be extubated. You still technically do fast track.
Yeah.
And you can just take the 5/5 a couple of days later. We've seen that a lot.
And this is a very random speculative question. You're also in a situation where you've got a catheter placed across the aortic valve, and therefore a means of drug delivery straight into the arterial tree without going through the pulmonary circulation, for example. Are we going to see more targeted pressors? Because we tend to talk about vasopressors, and we stick them in the venous side.
Right.
Can we?
Yeah, I would think so. There's an opportunity for sensing technology, for diagnostic technology, and for different types of therapeutics. Synergy, combined, localized pressor delivery. I think, why not?
Yeah. This is an enlightening conversation. I haven't done hearts for a very long time, but the thought of having this...
Well, you need to get back into
that's okay.
It's easier now. Look what we have.
Exactly.
It does feel like one of those transformational technologies.
It really does.
I think, people use the word disruption a lot, wrongly.
Yeah.
This really is.
Yeah.
This is really,
I
hate to use the term, changing the paradigm, but it kind of is.
Yeah.
And this
absolutely.
is like Courtney, and the work she does is so important for the community here to hear, because a lot of people say, oh, that's for the heart surgery.
Yeah.
It was, but not anymore.
Yeah.
The analogy I use is point of care ultrasound.
Yes.
Remember back in the day when the only people that had an ultrasound machine were radiologists? And now almost everybody in the room's got one.
Yeah.
In their pocket.
Sure.
This is similar, not quite as
Don't have it in our pocket.
yeah,
per se,
exactly. But the concept is that
Theoretical.
tools that are available to one discipline should now be available to everybody. And people like Courtney are leading that. I think that's really cool.
Courtney, fantastic work in this space.
Thank you.
Thank you for coming and talking to us about it. I hope we get to catch up soon and hear more about what you're doing at pushing the envelope.
Thank
Good,
you
or
very
pushing
much.
the needle. And thank you Annie, for coming
You're welcome.
as well.
Pleasure.
And thank you for listening to TopMedTalk. Again, you can find us on X, LinkedIn, Facebook, YouTube. We are there. Give us a thumbs up. Subscribe to our channel. Every little bit helps. Thank you to all of our sponsors for keeping TopMedTalk free and open access to the entire world. Please check out this conversation and other ones we've had about this this topic as well at TopMedTalk.com. Cheers, everybody.
TopMed Talk.
Thanks for downloading TopMed Talk. Don't forget to subscribe, check us out on YouTube, and of course on social media. We're on Instagram, Facebook, and X. Also, it's important to remember that TopMed Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.